All right, and I just want to remind everybody that we are streaming live. So from that, we're going to go and make sure you've all reviewed the minutes of the February 26th meeting. I'll ask for a motion to approve the minutes. Do we have a second?
Second.
All in favor?
Aye.
Any opposed? Any abstentions? Okay, I'm going to just start with the preface, Joe. So, if there's one true north, that's quality of patient care. This quality impacts outcomes. Outcomes impact families and impact lives. So, for me, this is one of the true norths for me, which is why I was very happy to partner with Joe and chair the committee. So, with that, I'll turn it over to Joe.
Excellent. And our true north is that every patient we touch will receive equitable, safe, high-quality, patient-centered care to afford them the ultimate patient experience. And truly, we have every employee working towards this and understanding that all of our employees have a voice. So today, our agenda that we're going to go through, Jen Lassett will share a patient story with us to start our meeting. And then we're going to move to Improving the Patient Experience by Maureen Sullivan. And then we're going to have a nursing annual quality review by Doctors Maureen and Bowden to go through the nursing quality improvement. And then we'll move into executive session for some ongoing discussion. So with that, I'd like to have Jen introduce our story.
Thank you, Dr. Golub. Good afternoon, everyone. Today, we will feature the story of Jim Highland, one of our patients. Jim suffered major burns in a hospital fire and was brought to our burn unit. Jim's niece, Kelly, who actually works here, contacted us to share about the wonderful interactions with all caregivers across the continuum of care while her uncle was hospitalized here, to include caregivers such as EVS, dining services, unit secretaries, social work, and more, which is what we love to hear in patient experience. And so with that, let's hear from Jim and Kelly directly.
In January, it was a Monday night, and I was getting notifications like on a Ring doorbell and neighborhood apps about a fire on Maywood and South Euclid. And I was texting my aunt instantly, and I was like, "What's going on Maywood?" And she called me back hysterical, saying it's our house, or it's on fire.
I remember going out to try to get away, but I had my rollator. And I got down the one side of the ramp, and then when I doubled back, I was already getting caught in the flaming embers that were dropping from the rafters of the garage.
Made it out of the house to the garage and had fallen. Two neighbors kind of dragged him out and were throwing snow on him to kind of put the fire out.
They discussed where they were going to take me. We decided to take me straight to Metro, which was good. That maybe saved my life.
Hey, Mr. Highland, how are you? You're looking really good today.
They were interested not just in what my current situation was, but the whole pattern of my recovery. Everyone had a personal relationship with me, even though they had to take care of so many people.
You are the type of patient that makes what we do so rewarding, because we saw you. You remember day one when you came in here? You remember day one? Oh my goodness, just absolutely so devastating. And to see today it's incredible.
Every person in my family had nothing but amazing things to say about the entire staff and the entire experience at Metro. From, not just the doctors and not just the nurses, but everybody, the social workers, aides, secretaries, EVS, nutrition. We were able to work through different Medicaid options and trying to find the appropriate rehab and skilled nursing facility for him. I mean, literally every person that I interacted with our family was nothing but top notch.
The head nurse, I wouldn't expect him to have such a one-on-one relationship. He never gave up. He was always there every morning. And it really helps with my mental outlook and my attitude, and ultimately my recovery.
our family would be totally and completely lost without Metro. All the help of all the employees and all of the staff, it's just been absolutely incredibly amazing.
I bet I get to come back there because you're my favorite.
I love that.
Continues his outpatient burn care here in our comprehensive burn center and has the amazing support of his family continuing.
Well, thank you, Jennifer, for sharing that patient experience video. I think, as most individuals in this room know, that, the Regional Burn Center is a crucial element of care for the community across Northern Ohio. So, it's been here for decades. I remember the days of Dr. Freddie Ann and Lynn Yurko from my old days. So Lynn and I were peers together. So anyways, great story, great outcome. So now we're going to turn to Maureen, who's going to give us an update on patient experience.
Come on up.
Okay. Good morning.
I
Thanks
have
for
my
having
sign
us.
for timing.
All right, we'll go ahead and get started. Go ahead, Maureen.
Okay, so today we're going to talk about 4 topics. One is reputation. Last time we met, we talked about an overall comparison to our local competitors. Today we're going to do a deep dive. Secondly, there's some changes to our surveys, particularly related to scales and the impact for providers and communication and how we're comparing ourselves and any improvements. We're going to talk briefly about complaints and grievances and just give you an update where we're at there and the associated work with improving things like communication to decrease those numbers. And then lastly, our focus for patient experience this year has been around empathy, and Jen's going to talk a little bit about work we've been doing there. So next slide, please. So reputation. So you probably remember last time we met in the fall, we looked at ourselves compared to our 2 local competitors, UH and Cleveland Clinic, and we did an overall score. So as you know, for patient experience, it's a 5-star rating. We are at 3 stars, but this is a deeper dive. What goes into those 5 stars are 10 dimensions or domains. There are several questions that go into each one of them, and this just gives you a visual comparison with our competitors. So the good news is, so yellow box means compared to the other 2, we're in the middle. We're sort of ranked number 2. Green, which you'll see in some other slides, I'm happy to say there is some green. We're number 1 compared to those 2, and then red is we're 3rd. So if we look at, I'm not going to go through the detail on each of them because of time, but if you go to the next slide, so we have 2 of them where we're yellow, so we're in the middle. The next one, 2 green and 1 yellow. And if we go to the last one, we have a couple red. So those are really opportunity areas around discharge and communication and teaching. So if you sum all that up, there are 4 yellow middle, 3 red and 3 green and 2 red. So that kind of gives you, yes.
I have a question about the 2 that were red. I just wondered, is there any difference in our patients? I mean, their ability, sort of their reading levels and comprehension levels and things like that. Does that play into this at all?
It plays into the score. It's not adjusted for that. So you're right. That's one of the challenges. And I think we do a lot of work around documentation and teaching that is a 6th grade level, and to make sure language barriers like Spanish speaking or other languages that we use interpreters to really make that, because most of all this work is about, it boils down to communication. So thank you.
Sure.
And just one thing to comment, you'll see it a little bit later in the slide, but the 894 surveys and that 14% response rate, and we're going to talk a little bit about that as well in upcoming slides.
So we go, okay, so this is a slice for inpatient, which is HCAP, so it ties to the slides previous for our system goal. So there are 10 dimensions there. As a reminder, the CMS made some changes this year in 2025, so we are establishing a baseline for one of the dimensions. It's going to be care coordination. Previously, it was called something different, so we're only having 9. But if you look at inpatient, and I'll credit Candy and the inpatient team, nursing really has done a lot of work around moving these scores. And happy to report, if you look at the very bottom, the star rating, we use the same methodology that CMS does. We can't totally, sometimes they do a little bit of calculation with case mix and severity, et cetera. So when it gets published publicly, it might be slightly different, but we use very similar methodology. And if you look at the year for 2024, we are hitting just barely, just made it by a smidge, 3.5, which will be 4 stars if we looked at this period. Now, I don't want to overcommit because again, CMS might do some calculation and we might miss it by a hair, but that's great news because we've done a lot of work, and it's I always say the line to excellence is not a straight line. It's a little bit jagged. You kind of make 2 steps forward, 1 step back, but the nursing team has really done a lot of work with hourly rounding, the nurse managers talking to patients and really trying to resolve issues on the spot. And I think there was a lot of discharge teaching, and the results sort of speak for themselves. So really pleased with those results for last year. So we move ahead to the next slide. Some changes. So this slide probably looks familiar to you except for the blue and green boxes. We came to you to say our response rate, as Dr. Golub said, was low, especially when we compare to our local competitors. It was like in the 14% range. So we thought that that was really not a great representation of our patient population. So we had the option through CMS to do a phone call. It's a live human that will call a patient, read the questions, let them answer. So our patients, we found from other surveys that we did that were not the CMS designated ones, they like that methodology. We also have email and webmail to be able to do some, and texting as well. From our real-time data, they like different modes of communication. So we decided to go with all the options available to us, and happy to report for that change where our response rate has increased to about 22%. So that's a pretty significant increase. So we're getting more voices. It's still not enough. We survey every patient. They don't all respond to us, but the more voices we hear, the better we can really take that feedback and make good interventions. So just wanted to close the loop with all of you on this. We go to the next slide. Okay, so one of the things we did when CMS made their changes, which is the dimension I talked about earlier, we took the opportunity to look at all of our questions that we have for patients, and we really are trying to standardize. One of the tools to quality and consistency is standardization. It gives teams a knowledge of how to compare data, so it's always kind of the same methodology, so we can know how we're improving. So we looked at, and some of the questions were different than others. So some were 3-point scales, some were 4-point scales. The best practice is a 4-point scale. The best way to ask the question is to do it in an order that is, the no is first. So you make patients really kind of pay attention and they get to that yes that really describes their experience. So if you go, these questions, these scales change. So we go to the next slide. This is kind of the why, and I'm not going to read through all of this, but it's basically this idea of standardization, consistency with all the questions that we ask. So we really have a comparison, and we're really using a solid methodology for when we improve and we look at our data comparison from month to month, week to week, area to area. So just wanted to share that with you. The downside of this, which there's always a downside, because there is more of a range, the scores initially drop, because you have instead of 3 options, you have 4. So this is a year of sort of course correction, reset. It's hard for people to understand, especially some of our providers. Like, I was doing great, I was in the 90s and now I'm 88. It's like, that's the correction, but then you'll be able to really see the improvement more incrementally. So we believe that this was the time to do it when CMS was doing it, and we just did it across the board. So any questions on that, the why or the what?
So do we think our scores will drop then?
They have a little bit.
Just, but not on the HCAP.
Okay.
Not any.
This is our real-time survey. So every inpatient gets a survey. A
Right.
certain portion get HCAP surveys, the rest get our real-time surveys. So there's gonna be a change on the real-time survey.
Got it.
Providers have the ability to see their results live in Epic. So those numbers are gonna fall for them specifically. So it's gonna be this year of recalibration, if you will.
Got it.
So no change
On this basis, on our HCAPs, just on our real-time survey.
And HCAPS is, I call it a team sport. So we don't attribute, because one doctor might admit a provider on a Friday and then Monday it flips to a new provider. You could do it by the discharging provider, but it doesn't line up as easily. So we sort of just look at provider communication for inpatient, which is HCAPS. That's just how we review it. And it's sort of like we target everybody improving so that the score can rise.
2 questions.
Yes.
So are the action plans division-based? So is action planning occurring in each nursing division?
Yes.
Okay. And then for physicians, is action planning occurring at department base?
Yes.
I was looking for a physician answer, but that's okay.
Yes.
Nurses always speak for doctors.
Yeah, so we've gone to some staff meetings, especially to explain this change for providers. And we look at the data by, and it also in Epic, as Dr. Golub said, yes. And then the nurse managers all kind of lead that. So we meet monthly, we review the scores. The areas that are low, we give a little extra love. We do some simulation and we support them just because the medical units they're the hardest, as we know. So that's where we sort of divide and conquer and focus. Does that answer?
It does.
Next slide, please. All right, I'm gonna have Jen talk about complaints because she is our. You do the best. You do the best, and I'm happy.
Good afternoon, everyone. So within the Office of Patient Experience, we have the Department of Patient Relations, and we're here by CMS guidelines to truly be the voice for our patients. So patients come to us via email, walk-ins, we go to the bedside, patients can write letters and of course call us to share their experiences, like we heard compliments like Jim Hyland's story to kick off the meeting. And then we also hear concerns from our patients, which we classify as grievances. So by CMS guidelines, we must acknowledge and close grievances within a certain amount of time frame and respond to our patients in writing. And so we have 30 days to do that. And we work with all the system leaders across the entire system to collaborate and be able to investigate our patient concerns and respond to our patients. So we're pleased to announce that we have 100% 30-day grievance performance for the first quarter of 2025. And I'd also like to share that when we had the triennial Joint Commission survey here in December, we are surveyed on our process and we received 0 citations for that process. And they go through and pick random grievances and ensure that we are listening to our patients and responding appropriately. So we have a team, a manager, Mike Hansen, and 3 patient relations representatives. And they do really a lot to help our patients, connect our patients to appropriate resources. Very empathetic team, right? Listen to a lot of patients' concerns a day. Next slide, please. This is just an example of how we wanted to include an example of how we really use our patient's voice to make improvements. So, for example, the ODH has transitioned to a new grants management portal, which requires us to respond to a civil rights questionnaire. And it was specific to how many grievances we've received about accessibility and what do we do to resolve and help. So here are some actions that we've had within the past 2 years. You know, we've reinforced education across the system about language access. That's now part of onboarding at new hire orientation. We can do department-specific education about the use of interpreters. And that's definitely been one of the reinforcements that we've done to comply. We'll hear from patients about physical accessibility, so sidewalks, manual doors, going into restrooms, right? It's that user experience. And we work with our facilities management team to ensure that, you know, we install auto doors or change bathroom doors, or even you have to see it through the patient's eyes on roll throughs, right? We may see that the paper towel holder is underneath the sink and patients can't reach it. It should be over here, right? So we really use that patient perspective to make improvements. We look at patients who may have vision impairments and ensure that they're receiving phone calls for reminders. And we look at when you walk into clinics, and this is really big right now with our new ambulatory site coming, ensuring that, you know, the counters are low enough for patients, utilize wheelchairs to check in. And we're sure to have an ADA shuttle. Thank you, Brian. I saw Brian somewhere on main campus. So that our patients, you know, can access a shuttle if they have limited mobility.
What tools do you use for your language access services?
We have a third-party vendor called Seracom, and anybody in the system, we all have our little badges, Seracom badges, can access it, an interpreter through phone as well as through iPad.
Okay, WebEx, like.
Yeah. But, you know, that's why we definitely educate even at new hire orientation, because you never know. People say, I'm not clinical, right? You'd be in the hall. And, you know, we are all empowered and should help our patients and assist and serve in any way that we can. Yes.
What are the most common languages that require us to use this service that we hear?
The top languages are Spanish, Arabic, and Cantonese.
It's consistent for Northeast Ohio, actually.
ASL, yeah. Yeah, and we also can,
Yeah, go ahead.
oh, what was that?
No, we also have internal,
Internal,
yeah.
yeah,
we have live people that can come too.
for Spanish
For
speaking.
Spanish.
Mhm.
They
Are
can-
they
And patient.
certified?
Yes.
Yes.
Okay, I think that was,
Yes.
that's the key word. You have certified employees. They have,
Mhm.
Yeah.
federal government requires that your interpreter be certified.
And we make sure,
There's a national agency that does certification, both in American Sign Language and for, like, if you went to a foreign proficiency school, there's the Presidio in Monterey, there's a foreign language school for the armed forces. If you graduate from there, you get a certificate that's good for so many years. And there's,
so at the time of appointment, we can schedule our on-site interpreters or ASL. We work with local agencies, Cleveland Hearing and Speech, to ensure that we have the appropriate resources to effectively communicate with our patients.
And just one thing I'd like to add is the numbers that you saw there were grievances. And if we ever brought the complaint numbers that our representatives were able to, a complaint would be solved on that phone call. And how efficient and effective they are at solving problems right when they get the phone call. So that it doesn't have to go down into that grievance.
Absolutely. Thank you, Dr. Golub. There's different definitions for complaint versus grievance. Complaint is nothing egregious, nothing in writing, something that we could fix on the spot. And many times, as Dr. Golub said, if patients don't know where to call, they'll call patient relations and we can get them connected to whatever they need.
Just a quick follow-up question on the languages. What about unwritten dialects like Haitian Creole? Is that available?
Yeah, in fact, I think the latest number was about 120 different languages last year that we utilized through CIRICOM. And they're a really great working partner, and our language access leaders work closely with them. So if our staff encounter something that, you know, needs improvement, we can work closely with CIRICOM.
And having worked with those before, time just takes a little longer to get those sometimes. So if you know in advance, it's better, because it just takes them a little bit longer
Yeah.
to get the interpreter versus some of the more
Common language, they actually have them on the spot. Okay, thanks, Jen.
All right.
Are you still
Fine.
going?
Oh,
Okay.
I'll go. You can't kick me off the stage yet, Dr. Gall. And then as Maureen mentioned, we really do have a focus this year on empathy. So coming out of COVID, we were looking at really standard work, getting back to basics. We were within the Office of Patient Experience and our service champions really looking at service basics and service recovery. Now we're looking to elevate that experience because we want every patient to have an experience like Mr. Highlands in the beginning, where everyone across the continuum of care showed that compassionate, empathetic behaviors. So right now, we were actually challenged by our emergency department after hearing from patient grievances and looking at what we could do to really empower our staff to, you know, be more empathetic. And so we've developed this empathy in action curriculum. And again, we're working with Candy and her team to get into the inpatient soon, but we've been facilitating empathy in action within the emergency department starting in last fall, really, and we've seen great progress in their scores. So our sessions, it's, you know, time of reflection. And when you go back, you know, we hope that everyone can put into practice. We also talk about the importance of the pause. So if potentially you don't have a positive interaction with one patient, we come out of the room, pause, and we're able to provide the best service to the next patient as well as our interactions with our colleagues. And then finally, we just like to close with each year at the end of April, it's National Patient Experience Week, and we celebrate that. And the purpose of that week is to really celebrate our caregivers and the amazing work that they do every day to provide our patients the best experience. So this year we had collaborations with our arts and health department as well as Metro Healthy to have events for our caregivers. We had drum sessions in the Glick Center Performing Arts, which was a lot of fun. We had haikus. We, challenged our employees to submit haikus around empathy, and we had some really amazing submissions. It's great to see people who you wouldn't think would have that poetic side come out and submit some really amazing haikus. And then finally, we had a keynote speaker that was open to all at Metro Health, Dr. Adrienne Boise. She's the Chief Medical Officer at Qualtrics. She's also a national TED Talk speaker. If you go to the next slide, Dr. Golub, she was here in person as well as it was live streamed to the system. We had some great engagement from providers, frontline staff, everyone. And it's just really focused on the importance of empathy, especially in our roles here in healthcare. So we were grateful to be able to celebrate all of our caregivers then at the last week of April for Patient Experience Week. And there's a link. The link is here if you get the slide sent to me if you want to watch her TED Talk. We got a lot of great positive feedback from it. So thank you.
Any questions?
Yeah. So what service recovery tools does staff have at their disposal?
So we use it through interactions, through the care. So connect, apologize, resolve, and express gratitude. If we look at things like parking vouchers or things like that, some departments may have things like that. We have blankets, but we really want to empower everyone that even if it has nothing to do with them and they inherit a complaint, that we empower them to resolve or seek the appropriate people who may be able to help resolve the issue. Yeah.
Michael, do you have any questions?
Thank you.
All right, thank you, Maureen and Jen.
A lot of great work going on in patient experience, and we continue to raise our HCAP scores year after year. And last year was no different with a 7% improvement in our HCAP scores, which is very big. So we're going to move then forward to Dr. Morey and Dr. Bowden for our nursing annual quality review. So I'll turn it
So I
over.
just want to say it's very appropriate, the nursing annual quality reviews in the month of May.
Yeah, yes, yeah, the very.
For those that have to ask why, they can see me later.
Hopefully no one asks. Well, yeah, so I want to introduce Dr. Victoria Bowden. She is the director of our evidence-based practice and quality for nursing. She oversees our Nursing Innovation and Quality Council. And so I invited her to share with you all our quality improvement process here at Metro Health.
Good morning, everyone. I'm so honored to be here on Nurses Month at the very tail end of it. I'm sorry, we call it a month, not a week, right?
Should be a year, but.
I agree. Yes. I'm with you there.
And how can it be special?
It would be the most special.
So we have a pretty robust quality improvement process, and I'm not going to read the slides, obviously, but I'm going to tell you a little overview about our program. So I came to Metro Health about 16 years ago, and I cannot take credit for the quality improvement work that was being done. This predates me, but I have been part of this work since the day I walked in the institution. We have a long history of doing quality improvement projects with a focus on patient outcomes. And right now, our current framework for our EBP projects is the Iowa model. And some of you who are nursing nerds may be familiar with this. We also have been embracing some of the FOLD model. The full model came out of the Ohio State University, and several of our individuals have gone through the training, including myself and Dr. Morey. So my team has a huge focus on quality improvement throughout the system. For us to identify quality improvement versus performance improvement, we really talk about quality improvement with that EBP or evidence-based practice. and that quality or patient-centered outcome. We're going to talk a little bit about how we've started integrating and measuring performance or continuous performance improvement, which we were not really very targeted on in the past. So our process, and you can go to the next slide, Dr. Gallup, starts with this form. Our nurses are trained to complete this form. We always include a frontline staff member. We really do want it to be interdisciplinary, and this is just a screenshot of kind of the first piece of that form. But it really looks at what is the problem and where do we want to be. So next slide. This is new for 2024. In the past, we really focused on a fishbone diagram and looking at kind of what happened at the front end of care and looking at what the nursing staff is bringing to us. But we really also wanted to shift gears when it came to quality improvement and really look at embracing the evidence-based practice of it. So we created this table of evidence that staff have to fill out prior to intervening. And the idea is that all interventions really should come from the literature and really embracing evidence-based practice as a discipline of nursing at Metro Health. So we do require 2 citations. It does help us in our magnet journey because it gives us these quality improvement projects we can utilize when we're telling our magnet story. But the idea is that we took the table of evidence that we see in higher education and kind of took it down to the staff level nurses so that we could embrace them reading articles and really looking at the literature for their interventions. Next slide. We've also really started focusing our performance improvement or continuous performance improvement plan for the institution. Prior to 2024, this work was being done, right? Like we knew that there was change happening on the unit levels. They were looking at how they do their work. Many of us, thanks to Dr. Golub and our quality counterparts, went through the IHI training years ago, looking at Institute for Healthcare Improvement. Thank you. But looking at that plan, do study model, looking at making change in kind of a quick turnaround. But we were not as a discipline capturing this. So the next slide. So in 2024, we implemented a process improvement project planning form that really looks like our quality improvement planning form, but it has some subtle differences. Still engages the multidisciplinary team so that we're capturing the work that's being done with our provider colleagues, our social work colleagues. But really, next slide, looks at kind of that Lean Six Sigma process or that process improvement process. Looking at that fishbone diagram, we move the fishbone diagram here to capture that experience of the frontline staff. Because we know sometimes when it comes to process improvement, if you don't involve the frontline staff, you are not going to end with a good result. And we know that the people who are doing the work really know the answers. We just need to engage them. Next slide. So the Knowledge and Innovation Council is made up of a multitude of frontline staff and is head by myself and one of the assistant nurse managers who also went through the folds and has done some training on quality improvement. We look at the documents that are submitted, give guidance to our staff, look at general suggestions for them to improve. We help them differentiate between process improvement and quality improvement, really focusing on that quality improvement, having that patient-centered outcome. Is it a patient satisfaction outcome? Is it a safety issue? And we'll give you some examples at the end of those projects that we have instituted in 2024. And then we officially approve their projects so that they can get started and a letter is sent to them. Next slide. One of the things that that letter helps them with is they are our quality improvement facilitators, which are part of our clinical ladder program, are expected to do so many projects throughout the years for their portfolio. The nurse managers are also held to that requirement in their annual review. So it allows for us to constantly be looking at who's doing quality improvement, performance improvement, and how do we measure that. We do have regular reporting structure, so quarterly reporting happens at the nurse leader level. And then we have monthly outcome measures that are reported at the unit level. Our goal is to have all projects completed within 12 months. Really a goal looking at 6 months, but we know that sometimes change takes time. And then this year we will be giving credit for those performance or process improvement projects through the nurse manager evaluation tools. Some of the other things that we're working on is on the development of a QR code for our nursing staff that will live kind of out in the unit, so that if people have ideas for projects, they can click on the QR code. It'll take them to a form. They can fill it out so that those projects that kind of are coming from the front line get captured, and we can help funnel them through the right paths. This just gives you, yes,
I have a question.
yes.
So how do you support the nurses from a protected time to do project work?
So our staff do get some out of staff time. It's not exactly what we would like it to be, with productivity as well as staffing issues. We do have some protected time that they are able to get out and work on projects. Some people will work on it above and beyond. Some of our staff are 36 hours a week. And so if they work on a project above and beyond that time, some managers will support that through the.
Yeah, I'll say too, when we have opportunities, which are rare, but right now we have an opportunity, census is low. We don't need as many staff that are scheduled, that then they have that time, that opportunity to work on their projects. So we try to support them in that way as well.
And then we, my group, the clinical quality and evidence-based practice specialists, as well as the CNS group, work on providing that on the unit support.
Dr. Alexander, there was a question asked of me probably a decade ago by a nurse magnet surveyor at a former institution. So I'm kind of giving you a read of when that's the kind of question you may be asked at a magnet survey, accreditation survey. So.
We try to give them as much protected time as we can.
Open try or not strategies. Anyways.
Yeah, no, it is a challenge. I mean, it's
Well, you have to come up with a CARTS model approach like you do for physician productivity. You have clinical, academic research, teaching and support, and somehow you pull some protected time out. It's in the budget, but it doesn't count in the productivity metric. So your peers are doing that in the market. So just nothing that needs to be fixed right away, but when's your accreditation survey?
Our application is actually due next week.
And
So our anticipated survey will be the end of this year, more likely the beginning of next year.
So just some sort of more structured response to that question might be beneficial to you or whoever's in that room with the surveyors. So, okay.
Question, back to your fishbone. How concerned are we at this moment about the FDA's diminished oversight and the quality of, I'm thinking the product category, materials that we get? Obviously, we're vulnerable there. Is that something that's on our radar? Should it be on our radar? Are you thinking about that?
Yeah, I mean, we're always thinking about that through supply chain and others. It hasn't gotten to a point where it's made any of our more recent fish bones, but I'm sure it will as those things type of change. But that's always products. Those things are always on our lists for
I'm sure they are. I guess I have a particular sense of vulnerability on that in a variety of fronts, not particularly in our hospital though.
And it does become an issue. So we do have to make substitutions. Sometimes we've been pretty fortunate that our substitutions have been acceptable when it comes to products. We haven't run into, other than the IV fluid shortage, which we all kind of dealt with at one point. But we've been pretty fortunate that we have good partners in the community that we are able to make those substitutions, but it's definitely on our mind.
It'll be interesting to see the response to the change in the COVID vaccination for pregnant females, because the literature out there is pretty
Strong.
I was trying to think of a non-negative adjective. It's pretty strong, supporting the need for COVID vaccination. The other problem with the announcement from yesterday was the fact that initial vaccination in children over the age of 2 has been left silent. So revaccination, I think the literature could go either way, but initial vaccination for not at risk children over the age of 2, is a lapse in what was announced, and they're trying to get guidance on it. So I think we're all in for a turbulent ride as we look at the changes. So.
Yeah, and we, from a clinician side, we saw some complications with pregnant individuals during the midst of COVID. So it was a concern of, I think, all of us. Yeah. So these, okay. So looking back at our numbers, these are our numbers over the last year. I mean, we've been pretty fortunate. So these are active or closed nursing QI projects that have gone through the institution. We started measuring PI kind of late last year, and you can see our dip in number. What we saw is some shift between the two. So we'll see how that stabilizes over time. Next slide. As you can see, our quality improvement by area, obviously outpatient has more projects going. They're just bigger. We see way more system projects working at the outpatient, and we really have put a lot of focus in our outpatient areas. I'm lucky that I have 2 individuals who focus mostly or almost exclusively on our outpatient side. This I talked a little bit about earlier, and that is how we hold our managers accountable for really driving quality improvement work on their units. Through their evaluations, as well as our portfolios with our clinical ladder program. I think the next slide is to talk a little bit about some individuals, projects that are working through the institution. These are some examples, and these are just examples of ambulatory projects looking at patient satisfaction outcomes related to delay and wait times. This was a huge project, and it was very successful, started in express care and moved throughout the system. Endoscopy is working on a patient satisfaction and education project that really looks at our would you recommend the facility, and really has shown actually they have outdone their goal for the end of the year. Next slide. These are quality improvement, looking at quality of care. So our Metro Life Light also participates in our QI process, and they focused on adult intubation first pass success, which if you're being intubated, that's the way you want it done in the first time. We are looking at, so this next project with using this Luminetics core really looks at early screening for retinal defects in patients with diabetes. This started in one internal medicine clinic here and has spread throughout the system, and we have multiple clinics because it was so successful. Looking at obviously early detection of retinal problems. Next slide. Our ERAS protocol, we started the work with ERAS kind of before COVID kind of got derailed. So our perioperative folks are working on ERAS, which really has a direct impact on length of stay. Inpatient pediatrics is working on a patient satisfaction, but looking at comfort and pain, something that's more formalized. Families can pick from a menu of pain control options, whether that's distraction, use of child life, things like that. So we're super excited about that project, and it actually is just beginning now. Next slide. Our favorite, those of us who've been nursing long enough, this is my 30th year of nursing, but looking at patient falls and looking at pressure injury prevention. This is something that we're constantly looking at. There are multiple units who are working on this based on their benchmark and their comparison to the benchmark. Next slide. Yes.
I'm gonna ask, sorry.
Oh, no.
Go back to slide.
Yes.
So under the pressure injuries, I'm assuming there's a requirement for an assessment on admission.
Yes, we do a 2% assessment on admission.
And what percent of the patients don't get assessed? Because that would lead to, so if you don't do the assessment and you end up with a pressure score, it counts against you, but if you come in with a pressure score.
Oh, yes. So actually, we've been successful. We had a QI project that was called Picture This. It was done a few years ago, and any spot on a patient is a picture is taken so that if we have a pressure injury starting on admission, we catch it. So it's not, we're not essentially.
On admission, or just if there's a spot.
They don't do a total skin pictures, but they are doing a dual skin assessment on admission, and that is 100%. I mean, they have 24 hours.
It's an epic, Joe.
Yes. And it goes up into media manager, and one of the nice things is it helps our WOCN team to go back and look at those
I don't know
and
what that is because they're.
wound care, I'm sorry, our wound care team to go back and look at it to make sure that it was what type of wound was on admission. And then we instituted the LEAF project, for those of you who probably don't know that. It's actually a sensor that sits on our patient's chest, and it measures our degree of turn. So there is a recommended degree of turn when it comes to patient, and it gives them a benchmark of how they're doing on their unit. It's there's certain criteria that for patients who get a LEAF. So it's been a really great project, and it started in our ICUs, but has spread out to our med-surg unit. So that's one really nice thing about having this centralized, is that good projects like that just don't sit in silos. So they're spread, like the Luminetics project and the LEAF project. We talked pairing with our patient experience colleagues. We worked on a multimodal approach of team communication on one unit who was really, really struggling with their patient satisfaction scores. We did simulation to look at those things. Postpartum is working on a newborn falls, which every time I say it, it makes me a little sick to my stomach. But we had a few moms who dropped their babies, fall asleep during breastfeeding. There's physiologic reasons, but we're working on a project, and potentially this is going to turn into a research study. There is no tool out there to measure that kind of sleep.
Just to say where that project was born out of the safety event reporting
Yes.
system. So the safety nurses placing these into the safety event reporting system, Stacy and the patient safety team noticed the trend, went to nursing, and that's how this project was born. So it's just an example of full spectrum of that particular project.
Yes. Go ahead, next slide. Some different projects. The NICU Golden Hour, looking at hypothermic patients with our very low birth weight babies. It's a measure of mortality. It's also a measure of sepsis in those patients. And then looking at the clinical screening for depression, which is one of our core measures for ambulatory. So lots of great work being done at the nursing level. Next slide. Any other questions for me?
Questions for nursing? Very welcoming.
You're fine.
They're
I
very.
told her, I said Ron's gonna have questions.
I love it.
So if you go back a slide though, so this goes back to a passion. So if you really here is to do no harm and to promote a safe environment for patients, things like, reducing percent of hypothermic, very low birth weight babies from baseline is important because that improves outcomes. If you think about a parent dropping a child and having a serious harm incident to the child because a parent fell asleep and we're doing something to prevent that, again, reduces harm to the patient. It's what the core mission is, but there's downstream impacts because it does reduce lawsuits, it does reduce costs for the organization related to extended length of stay. But the core is it's treating patients like your own. You would do that for your own family, so you're just trying to do it to your extended family, which is the patient population we serve at Metro. So to me, this is core to who we are as an institution. So.
And I truly am honored to be a part of it. I mean, I started as a clinical nurse specialist here and kind of moved into this position, and it is essential to what I do every day when I come in and my team, so.
And they're very welcoming, so physicians are on these projects too.
Yes.
So we're not excluded.
They do have their own projects, but we do pull them in.
Yes, so, all right.
Thank you.
Okay, that'll end our open sessions.
So now we're going to move into executive session to discuss hospital trade secrets as defined by the Ohio Revised Code 1333.61. Consider the appointment, employment, dismissal, discipline, promotion, demotion, compensation of a public employee, or the investigation of charges or complaints against a public official in the conference with the public body's attorney to discuss disputes involving the public body that are subject to pending or imminent court action as defined by Ohio Revised Code 121.22G. I'll need a motion to recess an executive session. So moved. For a second? Second. Okay, I'm gonna do, we need a roll call. Artis Arnold. John? Yes. Marie's not there. Right. Sharon's not on. Ron Jujitsky, yes. Michael Summers.
Yes.
Dr. Walker.
Yes.
I think I got them all. With that, I'm gonna ask the public to step out and we are gonna go into executive session.
Mr. Chairman, I meant that we want to ask everyone to step out who's not presenting, and also including Dr. Alexander Mistake, Dr. Gallup, Dr. Ade, Dr. Lewis, Dr. Stepnick, Dr. Morris, Michelle Block, and Tamika.
So amended. All right.